biopsy, fan needle biopsy specimen. So outside red, the FNA specimen shows acellular specimen, extracellular mucin present. And CA level is pretty low, 1.6 nanogram per ml. Amylase level is pretty high. They also did molecular testing, shows no amplification in both KRAS and GNAS. Now, will you change the diagnosis? The question actually we discussed in our tumor board because our surgeon mentioned if the diagnosis is mucinous cystic neoplasm, then they will do the resection. I obviously encouraged my surgeon, so the resection specimen arrived at my table. So this is representative slides for the resection. You can see here. This is the prior procedure side. The tissue shows necrosis. Here we can appreciate cystic lesion. At this power, we obviously appreciate ovarian type stroma. Let's focus on the epithelial lining. The epithelium is cuboid or low columnar. It's really hard to spot mucin. So I performed mucin carving again. Highlighted rare cells shows intracytoplasmic mucin. I also again performed ER and PR. Again, PR performed better than ER. The final diagnosis is mucinous cystic neoplasm low grade. The original small biopsy diagnosis remains the same. So this case, following this diagram, the algorithm here. Mucinous cystic neoplasm is a cyst-forming, mucin-producing epithelial neoplasm associated with distinctive ovarian-type subepithelial stroma. It's more common in women, mean age 48 years old. There's no connection of this neoplasm to the pancreatic duct. If you use IHC, ERPR can highlight ovarian type stroma, cystic fluid, chemistry usually CEA level is elevated, but amylase level remain low because there's no connection to the pancreatic duct system. Molecular testing shows KRAS mutation. If there is a TP53 mutation deletion of SMAD4 or P16, or called CDKN2A, supports high-risk cyst. Features suggestive of associated invasive carcinoma include size more than 5 centimeter, irregular thickening of cystic wall, intracystic mural nodule, or elevated serum CA19-9. So main differential diagnosis of MCN is IPMN. So IPMN shows communication with pancreatic duct, but MCN does not. IPMN does not have ovarian type stroma, MCN does. Molecularly, IPMN can show alteration in KRAS and NRAS, but MCN usually just the KRAS mutation. So what the challenging point of the first case is because the tissue is so small, and the second one not supportive CEA level. So I'm trying to explain why this is cyst fluid shows low CA level. I'm thinking in the imaging study shows a mucin ball in the center of the cyst. I was thinking whether it's from acinatus and absorb all the mucin, so left rest of fluid as serous like. So CA level remain low. And also this case shows false negative in molecular testing. Is the explanation most likely because of poor DNA quality and quantity. So the learning point of this case is a low level of CA does not exclude a mucinous cyst. It could be as low as 1.6 nanogram per ml, like my case. The second point, the absence of genetic mutation is uninformative, but the detection of mutation may be diagnostic. So let's move to case 2, 23 years old male, history ulcerative colitis, image study showing numerous pancreatic cysts. MRI confirms more than 10 cystic lesions are present throughout the entire pancreas. The biggest one, 4.9 centimeter. MRI suggests the IPMN, branch duct IPMN with enhancing mural nodule. FN-A and FN-B using transgastric approach was performed this shows the largest cyst, 4.9 centimeter. This is really representative field for the thin prep preparation. What we can see is a lot of hemocyte-laden macrophages. Background have some RBC and lymphocytes. Other than that, it's not dirty background. Somewhere I can see some epithelial cells. Remember, this is transgastric route, so I think this is just the contamination, GI contamination. So what's the diagnosis or differential diagnosis? Okay, come back to the diagnostic algorithm. Again, this case, I didn't see epithelium. I also didn't see mucin. So the differential diagnosis include pseudocyst, lymphangioma, or possibly other entities. This case does not look like a pseudocyst because it does not shows dirty background. As mentioned, it's pretty clean. Does not show hematoid like the pigments or any more macrophage inflammatory debris or fibrosis debris, cellular debris, right? So it does not look pseudocyst morphologically. It does not support diagnosis lymphangioma because in lymphangioma we are supposed to see numerous lymphocytes. So what could it be? The case also sent for CA and amylase. Both are low. Both levels are low. Glucose shows 114 milligram per deciliter, means support is not a mucinous cyst. The case also sent for molecular result. You can see here, there's no gene mutation was identified. So the cytology diagnosis is non-diagnostic or negative for malignancy. I think different practice cytopathologists maybe pick non-diagnostic or just give negative for malignancy. So this is just a different practice. I sent out the case as non-diagnostic specimen. I remember we also have fine needle biopsy. In the background, a lot of blood clot. There is a small focus shows bland epithelial cells. These cells are positive for inhibin, negative for chromogranin, and synaptophysin. The final diagnosis is most consistent with serous adenoma. So serous adenoma usually, majority of cases would show some even few epithelial cell, but would usually have some bland cuboid epithelial cell. The diagnosis algorithm following here. But this case, I would put here because I didn't see epithelial cells. Serous adenoma is also more common in female, mean age 65 years old. Majority of patients shows asymptomatic, but could show abdominal pain. Imaging-wise, it could show macrocystic or oligocystic. A characteristic imaging finding soap bubble pattern or sponge-like appearance. It could have a central stellate scar with starburst pattern of macrocalcification. Cytologically, it usually show epithelial cells. These epithelial cells are non-mucinous. Background will show blood, hemocyte-related macrophages. Chemistry, usually CA and amylase level are low. Genetic orientation usually involve VHL genes. This entity usually shows negligible malignant transformation. If patient asymptomatic, clinical just follow up. This case, the challenge point also shows here low cellularity in both fine needle aspiration and fine needle biopsy. Also, it's negative in molecular testing. It also could be due to poor DNA quality and quantity, and this case also shows no gene alteration involved. The learning point for this case, cytology with abundant hemocyte-laden macrophages, low or even absence non-mucinous epithelial cells. Just think of this MCT. The absence of genetic mutation is uninformative, but the detection of mutation may be diagnostic. Move to case 3, 76 years old male, pancreatic cyst at head and tail. Prior cytology diagnosis shows tail cyst, neoplastic mucinous cyst with at least high-grade dysplasia. Head cyst also shows neoplastic mucinous cyst consistent with IPMN with at least high-grade dysplasia. So the total pancreatectomy was performed, and I received. This really representative histology of this cyst lesion. All the lesion confined in the ductal system and involve the entire pancreatic ductal system, the entire pancreas. This lesion shows very complex architecture. You can see papillary tubules, and cytologically, the cells shows abundant eosinophilic cytoplasm. The nuclei enlarged with prominent nucleoli. The tumor cells are positive hyper and mark 6. The final diagnosis is introductal oncocytic papillary neoplasm of pancreas, or called IOPN. By definition, it's high-grade dysplasia involving the entire pancreatic ductal system. There's no invasive adenocarcinoma associated with this IOPN. Sorry. So IOPN is very rare, only account for 4.5% of all intraductal neoplasm of pancreas. Median age 59 years old. Most are incidental findings. Histologically, again, architecturally, it's very complex. The tumor cell shows granular eosinophilic cytoplasm with large nuclei and prominent nucleoli. The tumor could contain some mucin-secreting cells, including goblet cells, by definition classified as high-grade dysplasia. About 30% of cases associated with invasive carcinoma. You can get IHC hyper and mark 6 positive. Molecularly, it's recurrent gene fusion involving PRKACA or PRKACB, shown here. Those are fusion fusion genes. For the pancreaductal adenocarcinoma, usually alterated gene like KRAS, GNAS, TP53, CDK2A, or SMAD mutations are usually not identified in IOPN. Surgical resection is the treatment. Prognosis is pretty good. 5-year survival rate approaches 100%, but it does have local recurrence in as many as 45 of the cases. So this case, the learning point, IOPN could involve the entire pancreatic ductal system. IOPN morphologically and molecular is distinctive entity compared to IPMN. IOPN by definition is classified as high-grade dysplasia. IOPN, although have 30% of cases associated with invasive adenocarcinoma, 5 years disease-specific survival rate approach 100%. Case 4, 58 years old female presented with a growing macrocystic lesion at the pancreatic body, 3.6 centimeter. Prior cytology diagnosis shows mucinous neoplasm. Both CEA level and amylase level are very high. Since 1-year MRI follow-up shows the cyst slightly enlarged. So this distal pancreatectomy and splenectomy was performed for this case. You can see this is cyst lesion. Somewhere you can see clearly low-grade dysplasia. And somewhere higher power, you can see here, it shows high-grade dysplasia. And in one slide, just one slide, small focus, we see these two different morphology, especially this one. But this one, you can appreciate, it seems it's lymphovascular invasion, right? Even this one, at high power, you can see this is probably the muscle layer. So we also think this is lymphovascular invasion. And also, these tumor cells look different morphology. It shows abundant cytoplasm and rhizinoid nuclei. What we did, we did several immunostains. P53 shows wild type or more normal nuclear staining pattern. You can appreciate here. SMAD4 shows nuclear staining retained, but MTAP immunostain interestingly shows the tumor cell loss. This slide shows very good internal control. And then the entire cyst was submitted, and just the one small focus on one slide. We saw some areas seems like a microinvasion. You can see this gland shows similar morphology as the LVI cluster I showed just the prior slides. Abundant cytoplasm and pycnotic or rhizinoid nuclei. And here shows a little bit complex architecture. It's high grade, and some areas also shows the similar tumor cells. Since we just did the LVI tumor cells MTAP loss, so we performed MTAP on this slide. We can see as low power. Elsewhere shows retained MTAP, but MTAP immunostain shows loss in these two focus invasive component. And also interestingly, if you see this is ductal lesion, and somewhere shows the tumor cell MTAP immunostain loss, but somewhere it's retained, because here we consider as cancerization in this native tumor cell in the duct. Do you remember I showed this area shows high-grade dysplasia, and we perform MTAP just for learning this immunostain, and this high-grade dysplasia shows MTAP retained. So let's so this case final diagnosis is macroscopic foci of invasive adenocarcinoma arising in an intraductal papillary mucinous neoplasm, gastric tap with multifocal high-grade dysplasia. So let's talk about MTAP immunostain and the molecular basis. MTAP gene encodes so-called methylthioadenosine phosphorylase, or called MTAP gene, MTAP this protein. It is a very important enzyme in polyamine metabolism and salvage path of both adenine and methionine. This gene is located in chromosome 9 in the locus 9p21.3. We can see there's 4 important genes just adjacent to each other. And we can see MTAP gene, the neighbor is CDKA2A. The co-deletion of MTAP and the CDKN2A is very common in many tumor types, including glioma, pancreatic ductal adenocarcinoma, mesothelioma, urothelial carcinoma. MTAP immunostain, as I showed, is available. MTAP loss by HC basically completely loss of cytoplasmic staining. MTAP loss by HC is a specific surrogate marker for homozygous of MTAP deletion over MTAP and or with or without CDKA2A deletion, which has diagnostic, prognostic, and therapeutic implications. For the diagnostic implication, MTAP loss by HC supports the diagnosis of pancreatic ductal adenocarcinoma, especially in challenging cases. MTAP loss is seen about 20 to 30% of PDAC cases. In the prognosis implications, MTAP deficient PDACs is associated with metabolic reprogramming, poor prognosis, and immunologically cold tumor microenvironment. If the tumor is innate, has resistance to immune checkpoint inhibitors. To understand, here I also say the therapeutic implications. To understand that, let's see this figure. So there is a substrate. MTAP function as a rate-limiting enzyme for this reaction from substrate of MTA to the product MTR, and after several steps, methionine was produced. And then there is another reaction from methionine to the product SAM. Another important enzyme, MAT2A. Just remember here, it's also important enzyme. The SAM is very important methyl donor for this important protein, so-called PRMT5. Here, protein arginase and methyltransferase 5. It's very, very important in the regulation of gene expression. This here, mRNA splicing, signaling pathway, also DNA repairing or apoptosis, and a lot of more functions not listed here. If a cell have MTAP deficient, then the substrate MTA will be accumulated. Interestingly, MTA accumulation itself has partial inhibition for this important protein PRMT5. So we already know this protein is very important for cellular survival. If a medication target further inhibit this protein, it theoretically can can benefit the PDAX with MTAP loss, right? Or in other words, MTAP deficient PDAC will be benefit for the drug further inhibit this protein function. Another drug inhibit MAT2A, block the reaction from methionine to produce SAM. And then the PRMT5 lost methyl donor, basically. So these two drugs actually in the recent clinical trials demonstrate really the MTAP deficient PDACs benefit from the target inhibition of these two important proteins. Now I already talked about 4 cystic lesions. Now I will move to solid lesions. Case 5, 76 years old male, pancreatic body, solid mass, 2.3 centimeter. FNA was performed. So this is thin preparation. We can see this is a normal ductal epithelium and the lesional cell shown here. Another field, this shows lesional cells. Another field, these are normal epithelial cells, and these are lesional cells. A little bit higher power just give us impression all those tumor cells seems similar size. But interestingly, in this case, some areas show some tumor cells is really enlarged. This is also tumor cell, we think, and this is really pleomorphic tumor cells. It's another field. So what's the diagnosis or differential diagnosis? This is the diagnostic algorithm for solid lesion in pancreatic in pancreas. Pancreatic solid lesion in cytology, we usually see the first thing whether there is a cellular or acellular. If acellular, definitely is unsatisfactory. But if it's a cellular, but all cellular component just shows GI contaminants or pancreatic contaminants, then we also call this unsatisfactory. If it's not, then we think there is the specimen is satisfactory. Then we next step we will analyze whether cellular component is predominant or inflammatory component is predominant. If the inflammatory component is the dominant, then we think it's more likely chronic pancreatitis. If the cellular component is predominant, then they fall in 2 routes. If the cellular cells, they shows pleomorphic, then the differential diagnosis including PDAC, metastasis, and sometimes chronic pancreatitis following this differential diagnosis. This is in cytology field is well known. TRAP, chronic pancreatitis, can be false positively called as adenocarcinoma. If the tumor cells shows monomorphic morphology, then the differential diagnosis including neuroendocrine tumor, acinar cell carcinoma, solid pseudopapillary neoplasm, pancreatoblastoma, and sometimes if a cytologist serve on rows, sometimes it's hard and normal kick in as one of differential diagnoses. So for my cases, you see majority of cells seems monomorphic. So the differential diagnosis following neuroendocrine tumor, acinar cell carcinoma, solid pseudopapillary neoplasm, or pancreatoblastoma I didn't put here because that's usually seen in the pediatric population. But you should thinking of that. We have cell block. The tumor cells again shows majority of them shows monomorphic. The tumor cells negative for chromogranin, synaptophysin, INSM1, so it's non-neuroendocrine tumor. Tumor cells are positive for trypsin and BCL10. The final diagnosis for this case is acinar cell carcinoma. Another case, a different case, but associated is about topic. It's 56 years old male, presents with pancreatic head mass and a peripancreatic lymphadenopathy. FNA was performed. For the pancreatic head lesion, the FNA specimen shows very monomorphic tumor cells. It's also trying to form structures here. But for the pancreatic lymph node, interestingly, we see background in the monomorphic majority tumor cells. There's some cells really bizarre and enlarged nuclei. These two lesions from two sides, that's basically shows the same IHC, trypsin and BCL10, both positive. The diagnosis is acinar cell carcinoma. Acinar cell carcinoma is very rare in pancreas, only accounts for 1 to 2% of primary pancreatic neoplasms. This is a highly aggressive tumor. Usually occur in 50 to 70 years old patient, mean age 58 years old. Some patient could present lipase hypersecretion, perineoplastic syndrome. Grossly, this fleshy, large tumor, usually solid, well circumscribed. The mean size is 10 centimeter, very big. Histologically, it's just uniform, monomorphic, uniform nuclei with central prominent nucleolus. It could show fine granular eosinophilic to amphiphilic cytoplasm. The tumor is very enriched cells. It's very minimum stroma. You can use BCL10, trypsin, chymotrypsin highlighted tumor cells. This tumor could show focal synaptophysin chromogranin positivity, but not extensive. Molecularly shows BRCA1/2 ATM, PALB gene mutation, RAF family gene fusion is another big category, and also APC, beta-catenin pathway mutation. It does not usually the gene involved in PDAC like a KRAS, TP53, CDKN2A are wild type in acinar cell carcinoma. The top differential is pancreatic neuroendocrine tumor, pancreatoblastoma, or solid pseudopapillary neoplasm. So This one learning point is pancreatic acinar cell carcinoma could show some nuclear pleomorphism. In some cases, could be very striking. If you got the fine needle biopsy, probably it's not an issue. But if you just evaluate the smear or thin preparation cytology, it could be confusing. Don't be confused with PDAC diagnosis. Next case, 70 years old female with pancreatic tail solid mass. The mass is 3.0 centimeter. Fine needle aspiration was performed. You can see it's very cellular specimen. This lymph cell shows loosely cohesive. They're really monomorphic and trying to form some structures a little bit higher power. The tumor cells really like a big brothers and sisters and forming some circular structures. So what's the diagnosis or differential diagnosis? This tumor cells shows monomorphic. Again, is following the differential diagnosis list. The tumor, this case also have F1B, shows here. Again, in the F1B, see the abundant tumor cells, monomorphic morphology. This tumor, CK7 positive, CK20 negative, chromogranin just a rare cell positive, synaptophysin is dead negative. INSM1, this level of positivity. Ki67 is pretty high. So this is neuroendocrine tumor grade 3 because of high level expression of INSM1, or it is acinar cell carcinoma. Trypsin and BCL10 are positive for this tumor. So this final diagnosis is acinar cell carcinoma. The learning point for these two cases, for this case, is that morphologically, pancreatic acinar cell and neuroendocrine tumor could be very similar. Pancreatic acinar cell carcinoma could show scattered chromogranin and or synaptophysin expression. ACC could show quite extensive INSM1 expression. So do not just use INSM1. If you use INSM1 and you also perform the Ki67 and shows pretty high, just keep ACC in the differential diagnosis beside grade 3 neuroendocrine tumor. Another case, 73 years old female with pancreatic neck solid mass 1.0 centimeter. Fine needle biopsy was performed. You can see there's some lymph cells in the background, a lot of blood clot. This is a lymph cells. Morphologically, seems again it's monomorphic. This case, chromogranin is positive. Synaptophysin also positive, although not as strong as chromogranin. Ki67 is pretty low. So the diagnosis is neuroendocrine tumor, or do you want to perform other IHC? Yes, we performed carotene stain. A1, A3, CAM5.2 are dead negative in the tumor cells. SDHB is retained in the tumor cells as 100, with basically is negative. The final diagnosis is most consistent with paraganglioma. Paraganglioma in pancreas or pancreatic tissue is very rare. It's usually arising in extraadrenal chromophene cells of the autonomic nervous system. It could present primary pancreatic or parapancreatic lesions. It's pretty rare. A study with 9 parapancreatic paragangliomas. The fun facts list here. I don't go to all of them, but see here. On the radiological examination, all suspicious for a primary pancreatic neoplasm. Another fun fact, 5 out of 9 cases show cystic changes. And also another one, 3 out of 9 patients developed metastatic disease. Among them, 2 of the 3 actually died of the disease at 2.8 and 4.6 years after the diagnosis. Another paper studied 105 cases of retroperitoneal paraganglioma, shows one-third of cases S100 negative. And in this particular study, they claim negative for S100, negative for SDHB, and also intravascular tumor thrombosis were independent risk factors for tumor progression. So the learning point for this case is highly recommend doing keratin IHCs for a tumor expressing neuroendocrine markers. Don't miss the diagnosis of paraganglioma. In small biopsies, S100 immunostain could be negative. This case, we didn't perform GAD3, but GAD3 is also a good marker for the diagnosis of paraganglioma. Basically, keep paraganglioma in the differential diagnosis when you think of neuroendocrine tumor. Next case, 72 years old female, pancreatic head neck mass, 1.8 centimeter. EUS fine needle biopsy was performed. And this low power shows abundant tumor cells. And these tumor cells, again, shows monomorphic, plenty of tumor cells forming cyclostructures, and you probably can immediately now give the at least a differential diagnosis. This case, AE1, A3 positive, chromogranin, synaptophysin, INSM1, 3 neuroendocrine markers are diffusely positive. Ki67 is very low. The diagnosis is well-differentiated neuroendocrine tumor, WHO grade 1 of 3. Then the following pancreatic resection we received. This is low power morphology. Higher power, you can see very typical neuroendocrine morphology, neuroendocrine tumor morphology. Then the Ki67 seems a little bit higher. In the resection specimen, we give the diagnosis well-differentiated neuroendocrine tumor, WHO grade 2 of 3. In the most updated NCCN guideline published on October 1st, 2025, I want to highlight about neuroendocrine tumor, GI neuroendocrine tumor, several things. The NCCN guideline recommend Ki67 should be performed on all types of specimen, primary or metastatic, biopsy or resections. Ki67 proliferative index should also be assessed for every specimen sampled metachronously. When there are synchronous specimens from multiple primary tumors and or metastases, Ki67 should be performed on at least one block from each of the primary and metastatic lesions. I hope this is helpful for guiding our workup for our cases. So what we can learn from this case, the grade of pancreatic neuroendocrine tumor could be discordant in biopsy and resection. Ki67 should be performed in both biopsies and resections. In a small biopsy with limited tumor tissue, the definitive grading is best for resection. Next case, 78 years old male with pancreatic body/tail junction mass 6.0 centimeter. Prior EUS fine needle biopsy with diagnosis of pancreatic neuroendocrine tumor, WHO grade 2 of 3, now with distal pancreatectomy. This is low power view. So this shows different morphology. Right now, I show the morphology around here. You can see here shows typical pancreatic neuroendocrine tumor morphology, well-differentiated neuroendocrine tumor morphology, mainly coarse or tubercular pattern. And then now I want to show you some solid area here and here, the higher power from here. You can see this area shows solid growth pattern. In the higher power, the mitosis is really brisk, easily find. I count 2 millimeter square field. I count 26 mitoses. Ki67 at low power, you can see the area with uromorphology shows lower, but a solid area shows very high Ki67. Just shown here again, the typical area shows Ki67 like this, and the solid area with brisk mitotic activity, Ki67 is pretty high. This case, we performed A1, A3, performed neuroendocrine marker. Since Ki67 is so high in solid area, we trying to rule out the mixed tumor, the acinar cell carcinoma component. Trypsin and the BCL10 are dead negative, so we know there's no such component of acinar cell carcinoma. This case, sorry about that. This case, at the resection margin, very interesting, has the lymph node metastasis and one focus lymphovascular invasion. At high power, this lymph node metastasis, you can see the morphology looks even bad. If we that's the first slide we see this, we would think, oh, this is a carcinoma, isn't it? In the small focus of lymphovascular invasion, higher power shows similar bad morphology. We performed RB. RB shows retained in the nuclear staining of the tumor cell. P53 also performed, although it shows increased expression, but we do not think this is point mutant pattern. The final diagnosis of this case is well-differentiated neuroendocrine tumor, WHO grade 3 of 3. See note. We give the note, we talk about well-differentiated neuroendocrine tumor, grade 2 with a higher grade progression. So pancreatic neuroendocrine tumor, generally, general information is all pancreatic neuroendocrine neoplasm are malignant. It's also rare, relatively. It's accounted 2 to 5% all pancreatic neoplasm. In 2009, WHO is classified as pancreatic neuroendocrine tumor. Further have the G1, G2, G3 based on the mitosis and Ki67 proliferative index count. And the pancreatic neuroendocrine carcinoma further classified as small cell type or large cell type. Among pancreatic neuroendocrine neoplasm, majority of them just the pancreatic neuroendocrine tumor. Neuroendocrine carcinoma is pretty rare. Clinically, it's usually can affect both man and woman. Usually, neuroendocrine tumor is non-functional. Imaging shows well circumscribed solid mass, but as I talked before, neuroendocrine tumor can undergo cystic degeneration, so imaging-wise could show solid cystic mass. This paper published last year in Archive, basically talking about pancreatic neuroendocrine tumor and pancreatic neuroendocrine carcinoma are two distinct entities. Here list a lot of the differences including clinical presentation, histology, Ki67, and also immunohistochemistry. Immunohistochemistry obviously reflect the gene alterations. So here I want to just focus on gene alteration. Pancreatic neuroendocrine tumor involves gene alteration in DAXX, ATRAX, MANIN. In contrast, NEC involved gene alteration in TP53, RB1, and KRAS. Basically, the gene alteration in neuroendocrine carcinoma more close to pancreatic ductal adenocarcinoma. And also in this paper, talking about the precursors of these two entities. And they think like at least in MAN1 syndrome patient, the microadenoma can be considered as neuroendocrine tumor precursor for neuroendocrine tumor in pancreas, but never the precursor never was found in pancreatic neuroendocrine carcinoma. It seems all de novo. So this case learning point, G1-2 pancreatic neuroendocrine tumors can progress to grade 3 disease, indicating tumor heterogeneity and clonal evolution. Greater progression in pancreatic neuroendocrine tumor does not imply transformation to pancreatic neuroendocrine carcinoma. This paper also published in the last year, 2024. It published in 2022. Yes. So this one, this one shows abstract of tumor. Just let us focus on a few highlighted area. We can read together. Progression from NET to NEC is considered rare and it's not well described. This study studied a series of 5 patients that have low-grade neuroendocrine tumor that progressed to high-grade neuroendocrine neoplasm with co-alteration RB and TP53, similar to the pancreatic neuroendocrine carcinoma. And all 5 patients died of the disease. And this data demonstrate that low-grade NET can progress while the acquisition of both TP53 and RB alterations similar to NEC. But whether this represents a transformation from NET to NEC remain unclear. So this is very interesting area. I think more research will be followed in the near future. Next case, 74 years old female with history of pancreatoblastoma, presenting with bilateral adnexomesis concerning metastasis. A pelvic washing specimen was received. So in the thin prep preparation basically was read as negative. Fortunately, we have some tissue for making cell block. In cell block, we see several clusters of abnormal cells. Even this power, you can see this abnormal lymphoid cells is just slightly larger than the background inflammatory cells. And these tumor cells positive for A1, A3 negative for WT1, beta-catenin positive, negative for trypsin and BCL10. The diagnosis is metastatic pancreatoblastoma. Another case, 32 years old male with pancreatic head solid mass, 7.0 centimeter. The patient went through VIPO procedure. This is a representative histology. You can see some areas morphology like this, and some area morphology like this, look like squamoid component. And this area could be acinar cell carcinoma, ACC component, or NET component, and here shows squamoid component. This is diagnosis pancreatoblastoma. Pancreatoblastoma is also malignant epithelial neoplasm with multiple lines of differentiation. It's rare. 2/3 occur in children, 1/3 occur in adult. But it's the most common malignant pancreatic neoplasm in children. It's usually presented as a solitary, well-circumscribed mass. Macroscopically, as I said, the multi-lineage of differentiation. It could have acinar pattern, acinar ACC component, neuroendocrine neoplasm component, ductal component, primitive component, stromal component. But above that, squamous nests are the key diagnostic features. It is required for the diagnosing pancreatoblastoma. Genetically involve loss of 11p chromosome and also involve APC beta-catenin pathway. The survival rate is about 50%. Prognosis is worse in adult. So the learning point for these two cases, pancreatoblastoma is rare, especially in adult patients. Main differential diagnoses include AET, ACC, and SPM. Squamous components are the specific differentiation of tumor cells and demonstrate positive nuclear staining for beta-catenin. Always clinical information is very important. So let me do the bonus cases. It's 29 years old female rectal mass. So this is basically the main lesion. This morphology, we think you may have the diagnosis of tail gut. Interestingly, there's a small focus shows this morphology. And this higher power, you can see this is just like a normal pancreatic tissue, have the acinar component, neuroendocrine component, ductal component. Yes, I performed this just for educational purpose. I performed the CK7 highlight ductal and some acinar cells, trypsin highlight the acinar cells, synaptophysin highlight the neuroendocrine cells. Further, I also performed glucagon, somatostatin, and insulin immunostain. Shows those neuroendocrine nest shows multiple type of cells, alpha cell, beta cell, D cell, all there. So the final diagnosis is tail gut cyst and benign ectopic pancreatic tissue. Ectopic pancreatic tissue actually is rare. Study almost 100,000 cases, only 0.18% cases shows ectopic pancreatic tissue. And this lists some fun fact. The most common location is stomach, almost a little bit over half of cases. Followed by small intestine, omentum, mesentery, and this here other sites. Usually sites are small. So we learned from this case is one diagnosis does not exclude the second diagnosis, as we always taught bioanatomy. Although rare, ectopic pancreatic tissue can be seen in the tissue of abdominal or pelvic cavity. There is another case, 59 years old male with a peritoneal nodule. We receive resection. Resection, that's low power view, and a high power view. You may already have the final diagnosis or differential diagnosis. There's a little bit higher view for this tumor cells. It's very monomorphic. You can think about the differential diagnosis and confirm using IHCs. The tumor is positive for pancreatin, trypsin, BCL10. Only few cells shows the chromogranin positivity. Synaptophysin is negative. Ki67 is very high. Diagnosis: acinar cell carcinoma. So acinar cell carcinoma outside pancreas. This patient does not have any lesion in pancreas. So we think this is acinar cell carcinoma outside pancreas. Primary acinar cell carcinoma can occur in liver. You see this tumor, published paper, can occur stomach, and can occur ampulla of water, and also other sites, and I didn't include in these slides. It's thought to arise from ectopic or metaplastic pancreatic tissue. You can confirm the diagnosis using trypsin, BCL10, chymotrypsin immunostains. Importantly, you need to exclude the primary pancreatic acinar cell carcinoma. What we can learn from these bonus cases, acinar cell carcinoma outside the pancreas is present. Diagnosis need to rule out the primary pancreatic acinar cell carcinoma, thought to arise from ectopic pancreatic tissue or pancreatic metaplasia. Okay, I wrap up with the take-home messages. Diagnostic algorithms are very helpful for formulating differential diagnosis for both pancreatic cystic lesions and solid lesions. Multimodal approaches should be used in diagnosing pancreatic lesions. Be cautious when negative molecular testing result. False negative could be due to poor DNA, RNA qualities. A panel of IHC is always recommended for definitive diagnosis. Understand the classification and grading of pancreatic neuroendocrine neoplasm. Ectopic pancreatic tissue could have a malignant transformation. Thank you very much for your attention. I can take questions.
Thank you, Dr. Chen. Can you see the question, the answer box? I saw there are 4 questions. The first,
let me see the chat box, the Q&A box.
Yeah.
Where is my Q&A boxes? I have chat, but just show audio, video, participant, chat, share, pause. Why I don't have Q&A boxes?
Yeah, it's okay.
Oh,
I can
or
read
I
them.
stop sharing. Probably it come out. I stop sharing. Can I? Let me see.
Yeah.
Let me see. See whether. Oh yeah. Now I can see Q&A box. Okay. Oh, we already have some questions. Oh, thank Hanqiao is here. Do you do MTAP for PDAC cases for prognosis purpose as a routine? Yes, we perform MTAP immunostain for all the pancreatic ductal adenocarcinoma. It's mainly for include the patients for clinical trials. MTAP loss is completely cytoplasma staining loss. Those patients are qualified for clinical trial. Second question, have you ever seen a paraganglioma with CKAE1/3 negative, but cytokeratin positive? No, I haven't seen. I think if positive, how positive? Rare cell positive or diffuse positive neuroendocrine neoplasm, usually diffusely. Neuroendocrine tumor especially diffusely keratin positivity. But anything odd, when you see odd, you cannot explain by Euro scenario. You need double think. You can perform GATA3 to confirm diagnosis of paraganglioma. Can DEX-ATRAX help to distinguish neuroendocrine tumor versus NEC if RB loss and the P53 mutant can confirm NEC? That's a great question. I think if you attend many talks talking about pancreatic neuroendocrine tumor, we'll discuss about this. Yes, if a tumor, no matter is using IHC or molecular testing, shows the gene alteration involve DAX and HX, you really think this is neuroendocrine neuroendocrine tumor, well-differentiated neuroendocrine tumor. If shows RB loss, P53 mutation is much less specific compared to RB loss, especially RB loss is more specific for the diagnosis of NEC. I hope I answered your question. If you have further question or I didn't answer clearly, you can ask again. Next question, when do you perform stains on a pan net to rule out acinar cell carcinoma? Oh, that's a really good question. We receive several consult cases. Diagnosis, outside diagnosis is neuroendocrine, well-differentiated neuroendocrine tumor grade 3. But the reason they missed because actually, it's a Ki67 is very high. Whenever Ki67 is very high in a disease, in a case, you think of well-differentiated neuroendocrine tumor, it's the time to do acinar cell carcinoma, because acinar cell carcinoma usually shows high Ki67. That's a little trick. I think there's a few missed case. They didn't do trypsin or BCL10. We just simply perform that two stain and reach the final diagnosis, ACC, instead of grade 3 neuroendocrine tumor. Next question, is loss of MTAP specific for, so the next case, okay. And next question, is loss of MTAP specific for pancreatic adrenal when you have CK7 only, positive only adenocarcinoma of unknown primary? I don't think this is specific. As I said, this MTAP deletion is involve the chromosome locus 9p 21.3 co-deletion with CDK2A, which encodes protein P16. It can be seen many tumor types. So we cannot use just MTAP loss to think this is pancreatic primary. CK7 positive. Okay. Hopefully I answered your question. Next, do you perform acinar cell markers? Oh, it's jumped. Do you perform acinar cell markers routinely on all cellular neoplasm of pancreas? Usually, if it's neuroendocrine, well-differentiated neuroendocrine tumor, Ki67 is very low, probably not. Not all of the cases. Again, that's the trick part. If looks like well-differentiated neuroendocrine tumor, Ki67 is very high. Always perform BCL10 and trypsin, include ACC in the differential diagnosis. Next question. Thank you very much for the comment. Nice comment. Let me see. Next. Could you briefly share your experience and approach for mixed neuroendocrine neoplasms in pancreas? It's rare. It's rare, but it happens. Mixed, especially mixed neuroendocrine tumor and acinar cell carcinoma. In that scenario, you need to really think the possibility of pancreatoblastoma. So you need to search for the the squamoid component. In the small biopsy, if you see mixed component, you always give a comment. Comment is mixed tumor, or the possibility of pancreoblastoma is also in the differential. Ductal pancreatic ductal adenocarcinoma and neuroendocrine neoplasm also could be seen in pancreas for meaning diagnosis. It's really rare. I can tell you. I see just right less than 100 cases for meaning in pancreas. Let's see whether I have more questions. Oh, more questions. Okay. Nice martial arts. You recognize this martial arts uniform? You have good eyes. Everything. 火眼金睛啊。Okay, we can chat later. 师傅. So the next question, can MTAB, okay. Can MTAB distinguish reactive versus malignant? Yes. MTAB loss, again, cytoplasmic staining, complete loss, only seen in malignant pancreatic, in malignant tumors, not seen in the reactive tissue. G3 pancreatic neuroendocrine tumor versus NEC, mitosis count and Ki67 will not help. What other criteria? Oh, 师傅, have you performed P53RB and also molecular testing for the tumor can help guide the diagnosis direction. If the tumor involves the gene alteration in DAX-HX definitely is classified as well-differentiated neuroendocrine tumor. Again, G3 tumor usually shows heterogeneity. It could have low-grade component and could have a high-grade G3 component. It's usually considered as tumor clonal evolving, and some treated. Reading the literature, some treated tumor originally could be G1, G2, and then after especially heavy treatment with the time and could progress to G3. And NEC again involve usually does not have DAX HX those gene mutation, and it shows RB and P53 gene mutation. Again, I showed the paper talking about whether it's possible from well-differentiated neuroendocrine tumor to poorly differentiated neuroendocrine carcinoma in pancreas. It's debatable. There's a lot of academic interest. Thank you. So next, do you do both DPC4 and MTAB to differentiate reactive, malignant? What other specificity? I don't do DPC4. I usually in pancreabiliary area, actually, if I'm wondering whether it could be trying to help me to find the malignant versus reactive, I use P53, SMAD4, and MTAP. That's 3 immunostains to help me. My limited experience, they're pretty helpful. Okay, I think we answered all the questions, right?
Yeah, I think we answered all the questions. Yeah,
Okay.
thank you, Dr. Chen, for so many interesting cases, and thank you everyone to attend our lecture today. And yeah, have a good night. Thank you, everyone.
Good night, everybody.
Fantastic talk, Haiyan. Great job.
Okay, thank you so much.